Now I call upon Dr. Raghavendra sir, Consultant Medical Gastroenterologist, Railway Hospital, Perambur, to talk on the management of ulcerative colitis.
So, a very good morning, everybody. So, myself, Dr. Raghavendra Suresh, medical gastroenterologist I bring warm greetings from Southern Railway Hospital, Perambur. At the outset, I would like to congratulate Dr. Mohan Raj and Dr. Pawan and the entire VGET team for giving me this opportunity. One thing I liked about this conference is there's no time buzzer here or the timestamp which keeps running around in all the conferences. So I will take my liberty in completing this arduous task of talking about the management of ulcerative colitis. I'll try to restrict myself within the time frame. So to begin with, let me briefly outline the learning objectives of this talk. First, we will review the current medical literature and the various therapeutic modalities in the management of inflammatory bowel disease, especially ulcerative colitis, highlighting the key advances that have shaped practice in recent years. Next, I would like to address and apply a rational strategy for selecting and sequencing these advanced therapies which are available for the management of ulcerative colitis. The focus here will be on the evidence-based medicine, which translates into patients' clinical benefits with the least possible adverse outcomes. And I will also share a practical approach on how to translate the evidence into real-world clinical practice. Especially, the focus will be on the right therapy for the right patient and the right time. So with this, we will begin the talk. As you all know, ulcerative colitis is a type of inflammatory bowel disease. It's a chronic condition characterized by relapsing and remitting episodes of mucosal inflammation. Usually, the disease is limited to the mucosal layer of the colon, which distinguishes itself from Crohn's disease, which usually involves transmurally. The rectum is almost always involved, and the disease can extend up to more proximally to a variable extent. And this is the basis for the Montreal classification, divided into E1, E2, E3 on the basis of the sites of mucosal inflammation. And this happens usually in a continuous manner. Understanding this anatomical and histological pattern is very important for the diagnosis as well as disease monitoring as well as treatment selection. This basic framework helps us why UC is a distinct entity and we need to have a tailored therapeutic approach in the management of UC patients. So I'll take a bit of time to explain this slide. Earlier days, historically, when UC IBD was managed, it was all about symptom control. Later on, as many therapeutic modalities became available, many drugs became available, then the focus slowly started shifting towards the management of not just the symptoms, and it tried to evolve, and the STRIDE 2 consensus, which was published in 2021, which based its criteria from the earlier STRIDE consensus, refined the targets for both induction as well as maintenance of remission in IBD patients. We now consistently follow a hierarchy of therapeutic targets. At the foundation is the clinical response, which is the basic essential for managing these patients. You should treat your patients so that they get symptom relief. But this concept is now long gone. We have other targets like biochemical healing, which can be evaluated with the help of biomarkers like CRP levels and calprotectin levels. Beyond biochemical healing, we have now the endoscopic healing targets, which is a surrogate marker for mucosal healing in these patients, because mucosal healing corroborates with the remission in these patients, minimizing the complications as well as long-term disease modification. So the key message here is the goal is to achieve disease modification through measurable, objective targets. And the first and most critical step in the management algorithm is to determine which category these patients fall into, either a low risk or a high risk category. This is important because it not only gives us the choice of the initial therapy, but also tells us how aggressively we are supposed to intervene these patients. So the low risk patients are those patients who have limited proctitis or limited anatomic involvement disease with mild endoscopic features, whereas the high risk patients are those who are younger patients who have an extensive disease, who have high inflammatory burden, who are steroid dependent, who require repeated hospitalizations, and as well as develop other complications. And this risk stratification can be done by a number of tools. Some are clinical, some are the biochemical markers, which I'll be talking about. And you also use certain scores like the Mayo's endoscopic score for ulcerative colitis, which is a composite index in categorizing your patients on the low risk or the high risk category. So before initiating therapy in ulcerative colitis, a comprehensive pre-treatment evaluation is essential. Basically, I would put forth these pre-treatment evaluation to a simple 4-step protocol. One is the labs. You check the basic blood profile, the biomarkers, stool biochemical markers, CRP levels and other things. And then check for the bugs. You evaluate these patients for a superadded infection, specific pathogen related or a C. difficile infection. And then you scope these patients. Stable patients, you can proceed ahead with the colonoscopy. Unstable patients, you can consider doing a flexible sigmoidoscopy in an unprepared bowel. And then last, you biopsy these patients. So the order would be labs, bugs, scope, and then biopsy in that particular order. So moving on to the next slide. So I've divided my talk into management of mild to moderate, moderate to severe, and acute severe colitis. For patients with mild to moderate ulcerative colitis, aminosalicylates form a cornerstone of therapy. There are different formulations of 5-aminosalicylic acid is available, starting from the suppositories which act only in the rectum. There are other formulations of enemas and foams which act till the proximal sigmoid colon. And then the oral formulations. There are different types of oral formulations. The time-dependent formulations which start releasing the drug from the duodenum. There are pH-dependent formulations which start releasing the drug when the pH is more than 7. So the message here is you have to decide on the formulation for the right disease site, for the right patient, for the right outcome. So for proctitis and proctosigmoiditis patients, that is patients who have a distal ulcerative colitis. When managing these patients, the induction therapy should prioritize topical therapy, as this provides the highest concentration of the drug directly at the site of the disease. So topical mesalamine remains the first line of therapy. Like I said, there are different formulations for suppositories or foams or enema. You start these patients and on the topical therapy. If the mesalamine is not tolerated or failed, then you have the other options of topical glucocorticoids. Again, these are in different formulations of suppositories, foams or enema. You have different oral formulations, especially the budesonide MMX formulation, which has a specific colonic release. If these patients still fail on these therapeutic regimens, then you always have the savior in glucocorticoids. Again, gut-specific glucocorticoids as budesonide and the oral prednisolone. So this is a specific algorithm which illustrates a stepwise approach for the induction and escalation of therapy in patients with proctitis and proctosigmoiditis. We typically begin with a mesalamine 1 gram daily dosage topical therapy. It can be foam, suppository or enema. And you treat these patients for 2 weeks and observe for improvement in symptoms. If your patient improves, then they are good candidates for maintenance therapy with the rectal ASA formulation, be it any formulation. If no improvement, then you start treating these patients. You increase the dose of mesalamine to twice a day for another 2 to 4 weeks and observe the response. Your patient responds, put them on maintenance rectal ASA. If still the patient persists to have symptoms, then you always have the option of adding a topical steroid. Can be a hydrocortisone enema or a budesonide foam formulation, and your patient improve, then you maintain them on rectal mesalamine once a day dosage. Still, if your patient doesn't improve on rectal glucocorticoids, then you should consider adding these patients on oral ASA preparations for around 2 weeks, and then down titrate these patients on rectal oral maintenance regimens. And the last savior here, if still patients do not respond, then you have the options of starting steroids, prednisolone at a dose of 40 milligrams, or a budesonide MMX formulation preferably at 9 milligrams, and observe these patients. In case of left-sided ulcerative colitis or extensive ulcerative colitis, the preferred induction strategy is a combination of 5-ASA and topical mesalamine. The data suggests that through trials which have shown that there are two dosing regimens. One is the standard dosing regimen, and the other is the high dosage regimens. Anything more than 3 grams is high dosage, and 2 to 3 is the standard dosing regimens. Both are equally effective, and it has been shown that the lower dosing regimens, less than 2 grams, has been found to have more relapse. And in case of non-responders, you have the you can put these patients on oral mesalamine with topical steroids. If they fail, then you always have the option of starting gut-specific steroids like budesonide for 8 weeks. The beauty of this drug is that you can stop this steroid after, you don't need to taper, you can stop it straight at 8 weeks. And if your patients kind of relapse, then you can try with either a second course of budesonide, or you can switch over these patients on oral steroids. Azathioprine is one immunomodulator which has got specific steroid sparing effect, and in patients with steroid dependent UC or those patients who are intolerant to mesalamine, you can always consider putting these patients on azathioprine. After successful induction of remission in mild to moderate extensive ulcerative colitis, the primary goal is long-term maintenance, since relapse is going to be common without ongoing therapy. So all patients who have proctitis more than one disease flare in a year, all patients who have proctosigmoiditis or left-sided or extensive colitis, these patients are supposed to be on the remission drugs. Various regimens, like I have already discussed, mesalamine topical therapies are again available. The cornerstone of treatment is again mesalamine 2 to 2.4 grams daily. And after achieving remission, the next challenge for us is to sustain the remission to prevent the relapse. This often requires a structured monitoring rather than symptom-driven follow-up, because once patients achieve remission, surveillance must go beyond the clinical symptoms, because around 1/3 of the patients can have a disease flare even though they can be clinically normal. So what I would suggest is you put these patients on a surveillance colonoscopy after 6 to 12 months of attaining remission, and then you can also follow up these patients with the help of non-invasive biomarkers. The caveat here is, you have to interpret the reports of the non-invasive biomarkers with a pinch of salt. Ideally, CRP levels can be elevated in patients with high disease activity, but they can also be normal. The fecal biomarkers have a better positive predictive value as compared to the blood biomarkers. In patients whom you suspect a disease flare, the fecal cal more than around 150 micrograms, although the patients appear clinically normal, you should subject them to a repeat endoscopy. When patients fail to respond to the standard therapy, it is always essential to adopt a systematic approach rather than keep escalating blindly. The first thing I would do is check the complaints of these patients, because many of these patients on topical therapies may not tolerate these regimens. Basically they can be because of patient ignorance or because of the disease per se, where they're not able to hold the enema preparations. So ask your patients whether they are compliant with the medicines. Adherence rates can be, failure to adhere to therapies can be as high as 40% in these patients. The next thing I would reconsider the diagnosis, because you always have a lot of differentials. Solitary rectal ulcers or neoplasias or even IBS can mimic these patients. Also look for complications, especially proximal constipation, because it can impair the distal drug delivery, and these patients might not respond. In case of true non-responders, that is the patients who have been on these therapy but they still don't respond, the patients who have refractory disease, you always have the other possible treatment options, which I will be discussing briefly. So when we move to the domain of moderate to severe ulcerative colitis, conventional agents like mesalamine or steroids are no longer sufficient. So we have a lot of advanced therapies, but the key challenge is deciding which therapy for which patient. So this can be, this takes into account numerous factors. One by one is like, first one is like coexistent disorders. These patients usually have some other autoimmune disorders like psoriasis or psoriatic arthritis, in which these patients might be better responding to newer drugs. Also patient-related factors. Elderly patients who have other significant comorbid conditions like cardiovascular diseases or more prone for infection, newer therapies like ustekinumab or vedolizumab are better suited. Also patient preference for drug intake. Some patients might not prefer the injections, they would like to take an oral drug, wherein the oral JAK-STAT inhibitors or SMHB modulators score over. And in our setup, especially in India, when the TB prevalence is so high, the chances of patients having LTBA infections, latent tuberculosis, is quite high. So in this subcategory of patients, vedolizumab is a better choice. So, and I would say the most important thing is the cost or how the patients are going to afford. In a setup like ours, where I work in a government, central government hospital, where it's done free of cost, it doesn't matter. But in other setup where the patient has to pay, it becomes a big deal. And not only because of for the induction of treatment, but it also matters for the longer run for maintenance of these patients. So these are the different classes of drugs which I'll be discussing. First and foremost, we have the anti-TNF agents. TNF alpha is a pro-inflammatory cytokine released by the activated immune cells in the gut. It binds to the specific TNF receptors, TNFR1 and 2. And once they bind, then the TNF alpha stimulates similar cascade down the line in Th1 and Th17 response, and spiraling into inflammation, spiraling into inflammatory cytokines. The prototype molecules, you have three anti-TNF agents that can be used for ulcerative colitis. One is infliximab, which is an IV infusion. You have other subcutaneous injections in adalimumab and golimumab. Landmark trials of ACT 1 and 2 for infliximab, Ultra 1 and 2 for adalimumab, and pursuit trials for golimumab have shown that these agents are consistently shown benefit in both induction as well as maintenance remission. As you can see in the bar diagram here, this is one of the trials comparing, this is a VARSITY trial which compares infliximab with adalimumab, and shown that the combination therapy of infliximab with immunomodulator is better. And next you can have the other class of molecules, the anti-integrins. You can imagine like this as a cell charging point. Basically you have these integrin white blood cells circulate in the blood. To enter the gut wall, they use a hook on the surface, which is the alpha-4 beta-7 integrin, and they attach to the docking stations on the surface of the endothelial cells, called the MATCAM or the VCAM molecules. And once they attach, the hooks attach to the docks, then the lymphocytes enter into the gut wall, and they cause the inflammatory cascade. The anti-integrin molecules, of which vedolizumab is a prototype, decreases the immune response by preventing this gut immunity. And trials have shown that this is especially useful because it's more gut selective. It impairs the gut, it decreases the gut immunity, and it is also, since it is very gut selective, the risk of other infections or malignancy risk is quite low with vedoli. Only vedolizumab has a head-to-head trial with adalimumab, as shown in the VARSITY trial, where it has shown to be more beneficial in inducing remissions, as well as at the benefit of a lower infection risk. Next, you have the other novel molecules. These are the newer molecules, which act along the IL-12-23 pathway. The gut dendritic cells, once they trigger the danger in the bacteria or the immune triggers, they release the IL-12 and the IL-23 molecules. The initial IL-12 molecule acted against the P40 antigen, that is the ustekinumab, and the later novel IL-23 therapies, which act against the P19 subunits, are the gut selective IL-23 therapies which are available. The trials have shown that all these molecules, whether the IL-12-23 molecules or the more recent IL-23 molecules, mirikizumab, risankizumab, and guselkumab, risankizumab has been used in the treatment of psoriasis also, and these drugs have shown significant improvements in remission as well as maintaining remission. This is one of the novel molecules not yet launched in India but available in the US. This is the S1P modulators. S1P modulators are basically, they work like a traffic police. These molecules are lipid signaling molecules. One, they enter into the lymphocytes and they attach to the receptors, S1PR1. These are G protein coupled receptors, and they tell the lymphocytes that whether they have to move into the circulation or stay back in the lymph nodes. Once these modulators block the receptors, then the lymphocytes stay in the lymph nodes, thereby selectively decreasing the gut immunity. The advantage of this molecule is it is an oral molecule and it has got a faster onset of action. It starts as early as 2 weeks. You have ozanimod and etrasimod. It comes with a black box warning of mild cardiovascular side effect of bradycardia, but was not very significant, and you need to monitor these patients. And coming to this class of drugs, which is already available and in India, the prototype being tofacitinib, they work along the JAK-STAT pathway, which is a cell signaling pathway from the surface to the nucleus. Tofacitinib, as well as the new kid on the block, is upadacitinib. These have been shown in the Octave and You Accomplish trials that they have higher endoscopic rates of improvement in achieving induction as well as maintaining remission. These drugs are preferred in patients who have had anti-TNF failure, meaning they've failed on the previous anti-TNF regimens. You can consider adding these drugs. And the other advantage of these drugs is it is cheap cost and it's widely available. But you should always keep in mind that these drugs are also associated with important side effects like thromboembolic phenomenon or dyslipidemias, as well as infection. They also carry a serious infection risk. And glucocorticoids have been used for decades, and in multiple trials they have been shown to have induce a very rapid induction response. The only caveat of glucocorticoids is that you can use it for induction but not in maintenance because they are associated with serious side effects. Glucocorticoids play an important role in the management of acute severe colitis patients. This is just to summarize the different types of molecules. In practice, you have the anti-TNFs and the JAK inhibitors for speed, vedolizumab and ustekinumab for safety, and the ozanimod and this JAK-STAT inhibitors for the oral gut selective options. This is a wonderful meta-analysis which incorporated around 36 studies and around 14,000 patients. You can see on the far right, this is a visual meta-analysis diagram, network meta-analysis diagram, in which they have shown that the novel biologics like risankizumab and guselkumab have been ranked high in achieving clinical remission, and the oral molecule upadacitinib was superior to almost all the molecules in inducing remission and maintaining the endoscopic improvement as well as remission. Despite the availability of multiple advanced therapies, up to 1/3 of the patients might not respond to your treatment. These are the classic non-responders. Then you have to consider either switching to a different biological class or the oral small molecules, or you can consider a combination therapies for these patients. And once remission is achieved, and you have to continue these drugs as long as possible. For patients on anti-TNF therapy, you can continue as a monotherapy or combine with an immunomodulator. Also in the newer drugs like vedolizumab or ustekinumab, you have to continue these patients for long-term use. Even with effective maintenance therapy, a proportion of patients might experience relapse. The principle is that you need not escalate the drug or switch the drug immediately. There are different treatment strategies, evaluation strategies, of which the most important I would say is the therapeutic drug monitoring. This was initially applied for the TNF class, but now it's being used for even other classes. Basically, you measure the trough concentrations as well as the antibody levels. If both are low, then you have to increase the dosage or decrease the dosing interval. In case you have low level therapeutic concentrations of the drug but high antibodies, then it means that the biologic is no longer working and you have to switch. You can switch in the same class. But if your therapeutic level is going to be low as well as there are no antibodies, means that the drug has primarily failed and you have to switch these patients to a different class. So, despite all these novel treatments, a subset of patients will definitely fail your treatment. And in these patients, you should consider surgery as a definitive curative option. Please don't consider surgery as a failure of your treatment option. Indeed, you have to involve the surgeons upfront and from day one in the management of these patients. And it is one of the most important curative treatment strategies in management of patients with ulcerative colitis. A small word about the management of acute severe colitis. You diagnose these patients as per the clinical symptoms based on the true love and WITS criteria. Initiate these patients with the standard supportive treatment. The specific management of these patients is IV glucocorticoids. You start these patients on IV glucocorticoids. You monitor the response daily. Day 3 will be the judgment day. You assess the patients as per the Oxford criteria of the Travis index. And if these patients don't respond, then you have two options. One is infliximab, another is cyclosporin. And you reassess the patients within a time frame of another 3 to 5 days. Still no response, then the patient has to be taken up for surgery. And as far as patients who attain remission, the management of IV steroids or either infliximab or cyclosporin, you have to maintain these patients on either an anti-TNF plus thiopurine in most of the cases, or in case of cyclosporin, again you have to switch over to either thiopurine or vedolizumab. When the medical therapy fails, I already explained the role of surgery. With specific reference to the Indian scenario, you have the different therapeutic options. In case of mild UC, first line therapy is, I would like to reinforce that it is topical mesalamine. If they don't respond, then you can escalate to oral steroids. In moderate to severe UC, the first line therapy in these patients, you can consider oral or IV steroids followed by other oral biologic similars. In case of acute severe UC, you start these patients on IV steroids and you have the rescue regimen in infliximab or cyclosporin. JAK-STAT inhibitors, especially after biologic failure or in only select group of patients, you can consider. So as we look ahead, the landscape of ulcerative colitis management continues to evolve rapidly with the introduction of newer therapies and more newer drugs on the horizon. It's been changing completely. Also, word on beyond immunology, you always have the gut microbiota or FMT as a treatment therapy is being evaluated, and mostly clinical studies are coming up. So the key takeaways is we have moved on from the era of symptomatic management to the more advanced era of monitoring the histologic healing or mucosal healing and disease modification. And you have to strategically use all these molecules in the management of your patients. Embrace surgery as a valid option, and based on your patient, you have to design on the right therapy for the right patient at the right time. Thank you.
The last slide you showed is the adjuvant therapy is fecal microbial transfer. At least those cases of ulcerative colitis, ulcerative with Clostridium difficile, I think beyond doubt FMT plays a major role. That is what studies say. And we have witnessed 3 years back in Chennai arena, we have succeeded in mitigating this Clostridium difficile by performing FMT. What's your view, sir?
Sir, definitely FMT is coming up. It's now being mostly in research settings, but they have tried in ulcerative colitis. The data, it has shown, there are no randomized controlled trials of FMT in acute severe colitis, but the early data shows that it can be another therapeutic option when these patients don't respond to the usual line of treatment. For C. difficile, yes, definitely it has been, data is there for it is being used as a treatment option for management of C. difficile colitis patients.
Akkermansia motionophyllae, Picalibacterium prasunci are the new generation of probiotics which find place in these IBDs.
Sir, again, IBD, if you go to the data, VSL3, that is Bifidobacterium, live freeze-dried Bifidobacterium, which has been shown to induce remission in the patients with ulcerative colitis. They have been used for even inducing remission in the management of ulcerative colitis. Other molecules which have been tried but not to the great extent, it's not been incorporated into the guidelines as of now. Yes, sir. It's a live freeze-dried Bifidobacterium.
Sir, like as of guidelines, what probiotic they are telling, like for pouchitis, it will be useful, sir. Pouchitis, it may induce remission, especially pouchitis, and all of the therapies like only add-on therapy.
Raghavendra, nice lecture. I think you covered the entire gamut. But with the explosion of medications available and the hands itching to try new medications, I think we need to keep in mind that most of the patients which we see in India are only mild to moderate cases of IBD, for which probably the first line drugs would be still mesalamine and steroids. And in those patients who do not respond to these, probably you would probably like to try biologicals or disease modifying drugs like azathioprine. But as far as we are concerned, I think it's very rare. About 10% of patients come to you with acute severe ulcerative colitis or severe ulcerative colitis without complication. In these patients, again the remission would be steroids and the maintenance would be probably biologicals. One should remember that using biologicals straight away is probably not in the guideline. And once you want to start biologicals, you need to make sure that patient is not suffering from any other occult infection. So you need to probably check out for occult tuberculosis. You may require mantle, you may require a chest CT. Most of them will require a presumptive, probably treatment with INH for about 3 to 4 weeks before you start them on biologicals. And as far as C. diff is concerned, any relapse in IBD is probably your duty to rule out C. diff as possibly one that is precipitating a relapse. And these patients, you need to check. It's so simple. You need to do just a stool examination, look for the toxins, and then probably treat them. They get better. Then you continue the drugs you've already put. Biologicals are there, but we need to be careful to use them. It's all there. But you need to choose patients and make sure that only those patients who are requiring these drugs are given. He's given the entire list, but it is your duty to make sure that it is really required in these patients before we start. Tofacitinib is freely available, but nobody checks for herpes zoster antibody. One of the commonest complications of tofacitinib is it causes very severe herpes zoster in patients who have not been had before. So these patients, you need to check the antibody levels. If they are negative, you need to probably vaccinate them before you start medications. A lot of people on tofacitinib come back with severe zoster restriction. So it's very important that you need to probably choose your patients well, make sure there is no occult infection anywhere, make sure that you probably vaccinate these patients before you start them on. Even for steroids, they say that you need to probably vaccinate, especially for hepatitis B. So the idea is you have drugs, use them judiciously. That should be probably the take home message. There are so many drugs out there.
After initial therapy, sir, for ulcerative colitis, patient does well. Screening colonoscopy should be done how frequently, sir? 6 months once or once a year?
Sir, initial screening colonoscopy, after your diagnosis and you put these patients on induction regimen, and then once they achieve remission, then you should do the next repeat colonoscopy at 6 months. 6 months or 6 to 12 months. I would say that 6 months at the earliest, and then you can use the novel biomarkers like CRP and this fecal calprotectin levels you can monitor. These are surrogate markers for colonoscopy, mucosal inflammation, and they can also tell whether you need a repeat colonoscopy after that or not. If the fecal cal is more than 150 micrograms per gram stool, then you should consider doing a repeat colonoscopy with biopsy. And after 10 years, these patients have to be on surveillance for CA as well.
You said surgery as the last option, was it? Total proctocolectomy with ileal pouch, anal anastomosis. But those patients, no sir, they have persistent loose stools. It produces lot of perianal excoriation and pain and all, and land up in stricture out followed. So we have done almost
in refractory UC or in acute severe colitis patients who are not responding to your usual line of management, then surgery is a curative option. You have no other option left. So in those patients, yes, sir.
That too, after surgery with ileal pouch anal anastomosis, these patients tend to have liquid stools. They used to pass 10 to 15 times a day. Later they develop anal strictures, perianal excoriation, and land up in endoleostomy. I'm asking Dr. Kapil also how to do
diet modification, sir. You need to probably tell them how to take food, and then, because this is a common phenomenon for initial period. They normally settle down. Make sure they don't have pouchitis, and you need to put them on long-term rifaximin in these patients. Antibiotics also will be required if you probably think they have pouch infection. This patient usually settle down. The upside of this is that you cure them the disease. So once you remove the colon, then there is no more ulcerative colitis. If you have, surgeons will probably vouch, if you have pancolitis, you send it to us, we will operate. But now with so many drugs available, surgery for IBD has come down, unless it is complicated by stricture or by medications. This is a common problem, but probably they come over it, they learn how to, probably they'll modify the drug and take. Antidiarrheals can be used in this patient. It can be used, and it probably helps them. Probably.
Phase of intestinal rehabilitation. Till that time, definitely they'll be having the problems, and once, like sir has said, diet modification, and once you rule out other infections, anti-motility agents can be of benefit.
Could be part of the team. You cannot deal alone. I think you need to have your surgeon with you, and then probably they should be discussing. And so many other ways, CRP and fecal calprotectins are probably non-invasive markers to check for activation. Patients can have normal stools, they can be clinically normal, but it doesn't actually mean that they are endoscopically normal. It's not like that way. You will find that most of these patients passing stools once or twice, formed, no urgency, no frequency. Endoscopy will show still inflammation. So FC, you need to do FC every 6 months. If the SC is persistently high, then probably it requires an endoscopy. Otherwise, index presentation, regular endoscopies are really not recommended. But after 10 years, you need to put them on screening endoscopy to make sure, because once you have pancolitis, the risk for infection, malignancy is quite high. So these patients should be put on screening endoscopy at least once a year, even if they are asymptomatic, to make sure that you are not missing a malignancy in this patient.
Indications for surgery is mostly emergent now. It's not like the patient is referred for an elective procedure to a surgeon. So most of the times it's either fulminant colitis or a toxic megacolon where we have to go now for it. So regarding pouchitis, these are the subgroup of patients who have intermittent colitis. So some select subgroup of patients will have refractory pouchitis. For them, we'll have to continue lifelong rehabilitation as we discussed. But apart from that, it's a very selective group. So about 30% of patients develop recurrent refractory pouchitis.
Ulcerative colitis is quite common. It has got again bimodal presentation. We see a lot of patients ulcerative colitis. My previous speaker, Pawan, actually spoke about the patients with chronic diarrhea. Mostly these bloody diarrhea patients, always ulcerative colitis should be a first infection. And especially in this setting of, sir, the diet, lifestyle, so it has become more common.
Thank you, sir. In the interest of time, we end the session, sir.
Thank you for this insightful and elaborative session, sir.